Hi everyone, this is Heather Vernillo and welcome to week 2. We're reviewing chapter 12, which is neurotransmitters and the autonomic nervous system. In this chapter, you will go over classes of drugs that affect the autonomic nervous system, the uses and actions of these drugs, the absorption, distribution, metabolism, and the excretion of these drugs, and the drug interactions and adverse reactions to these drugs. So let's talk about the autonomic nervous system. What is it? It regulates the body's involuntary functions like your heart rate, your respiratory rate, and digestion. It's things that you don't have to think about. It's automatic, autonomic. It works through a balance of two main components, which is the sympathetic and the parasympathetic nervous system. Types of drugs used to treat things in the autonomic nervous system are called cholinergic, anticholinergic, adrenergic, and adrenergic blocking drugs. Now, let's talk about cholinergic drugs. What are they? They promote the action of the neurotransmitter acetylcholine. These drugs are also called parasympathetic drugs because they produce effects that imitate parasympathetic nerve stimulation. There are two major classes, cholinergic agonists and anticholinergic drugs. Your cholinergic agonists, when a neuron in the parasympathetic nervous system is stimulated, the neurotransmitter acetylcholine is released. Acetylcholine crosses the synapse and interacts with receptors in an adjacent neuron. Cholinergic agonist drugs work by stimulating cholinergic receptors mimicking the action of acetylcholine. Now, in our anticholinerase drugs, after acetylcholine stimulates that cholinergic receptor, it's destroyed by this enzyme. And these drugs produce their effects by inhibiting that from occurring. And as a result, acetylcholine isn't broken down and begins to accumulate. Therefore, the effects of acetylcholine are actually prolonged. So where do we see these? We will see them in topical preparations like eye drops. They are used orally, and you can see them sub-Q. Cholinergic agonists rarely will be given IM or IV because they almost are immediately broken down in the interstitial space between the tissue and inside the blood vessel. These are very fast operators. They are absorbed rapidly and they will reach a peak level in the bloodstream within 2 hours. And food will actually decrease their absorption rate. Less than 20% of a cholinergic agonist is protein bound. And these drugs are mainly excreted by the kidneys. So cholinergic agonists work by mimicking the action of acetylcholine on the neurons, and they go after what's called target organs. When they combine with the receptors on the cell membrane of that target organ, they will stimulate the muscle, and they can produce salivation, bradycardia, dilation of blood vessels, constriction of pulmonary bronchioles, increased activity of the GI tract, increased tone and contraction of muscles in the bladder, and constriction of the pupils. So then why do we use it? What is the pharmacotherapeutics of this medication class? We're going to treat weak bladder muscle conditions and post-operative and postpartum urine retention. We're going to treat GI disorders like post-operative abdominal distension and GI atony. We're going to reduce eye pressure in patients with glaucoma. We're going to treat salivary gland hypofunction caused by Sjogren's syndrome or radiation therapy. What are some adverse effects of cholinergic agonists? We can see nausea and vomiting. We can see increased saliva production and increased sweating. We can see increased urinary frequency, shortness of breath, a decreased heart rate and low blood pressure, blurred vision, cramps, and diarrhea. And back to the fundamentals of nursing and formulating a nursing care plan, what would be your assessment for this patient? We would look at myasthenia gravis, assess for urinary retention, bladder distension, determine the patient's fluid intake, the time and amount of their last urination, look for paralytic ileus or any paralysis of the small intestine by checking and listening for those bowel sounds and checking for abdominal distension and determining what's the patient's usual elimination patterns and have we deviated from the norm. You're going to assess for disorders that may be aggravated by cholinergic agonists, such as Alzheimer's disease. And think about your nursing diagnosis. What would be true and a good nursing diagnosis for this class drug? We could get ineffective airway clearance related to the increased respiratory secretions. We could have impaired urinary elimination related to the cholinergic drug action, impaired gas exchange related to the increased secretions, bronchospasm, or respiratory paralysis. And let's look at planning and outcome goals. What's our goals? Patient will maintain an effective oxygenation status. Patient will regain usual patterns of urinary and bowel elimination. Therapeutic effects of the cholinergic drugs will be observed. And then go into that further. How would you know? How would you know a patient was maintaining effective oxygenation? What's a simple thing that you could look at? A pulse ox above 95, mucous membranes pink and moist. We're looking at what's the color of their skin? What's the color, in their eyes? Like, how do we know a patient's getting oxygenated? Are they using accessory muscles to breathe? What is their respiratory rate? And we always want to assess. We're going to assess for signs of respiratory adequacy. We're going to perform measures to promote gas exchange. We're going to make our patients cough and deep breathe. We're going to suction our patients as needed. We're going to do proper positioning of our patients. We're going to assess them for urinary adequacy. What are some signs of urinary retention? How would you know? We're going to assist the patient in establishing a good drug administration schedule that will meet their needs and help them be compliant in their medications. And we're always going to provide patient teaching. What are some things that you could teach your patients? We're not going to chew or crush sustained release tablets. We're going to take our cholinergics on an empty stomach because that will increase absorption. If we're going to have any diarrhea or vomiting, we need to ensure that we are replacing that fluid loss. And cholinergic drugs for urine retention act within about 60 minutes of taking them. So the person needs to make sure that if they take that medication, that they are not going to be away from a bathroom when it kicks in. And we always want to educate patients that over-the-counter medications and a lot of these herbal supplements can actually interact with this class drug, and they should really speak to the prescriber of whether or not it's safe to mix their supplements with any of their medications. Things like St. John's wort is a classic example of a supplement that's very popular for the treatment of anxiety and depression that can affect bleeding times and can affect the blood levels of a lot of these cholinergic drugs like donepezil. Now let's go into a little bit about catecholamines. Because of their common basic chemical structure, catecholamines share certain properties, and they stimulate the nervous system, constrict peripheral blood vessels, they can increase the heart rate, and they can dilate the bronchus. They can be manufactured in the body or in a laboratory. Common catecholamines that you might see are dopamine and dobutamine, epinephrine, norepinephrine. And you can't take catecholamines orally because they will be completely destroyed by digestive enzymes. And then looking at sub-Q versus IM, which would you think would work best for this class drug? Now, absorption by sub-Q route is going to be slowed, right? Because catecholamines are going to cause constriction of the blood vessels right at the injection site. IM absorption is going to be more rapid because there is less constriction of local blood vessels. Now we have two different types. We got ones that activate and we have ones that deactivate. And a way for you to remember catecholamines have alpha and beta receptors. So alpha for activation, meaning they are excitatory response, and B for beta, meaning they're banishing it. It's an inhibitory effect. So what are we using some of these drugs for? Well, you're going to breathe better with that beta adrenergic activity. Catecholamines, they exert this beta adrenergic activity. They can treat acute bronchial, asthma attacks. They can help with emphysema. They can help with bronchitis. They can help with allergic reactions to medications. And dopamine, which stimulates that dopaminergic receptor, is used in low doses to improve blood flow to the kidneys because it actually dilates those renal blood vessels. Now, remember, when our patients tend to not just take one medication. So when we mix catecholamines with other drugs, we can have unintended side effects, like tricyclic antidepressants used with a catecholamine can actually lead to severe hypertension. Other adverse reactions are restlessness, anxiety, dizziness, headache, palpitations, cardiac arrhythmias, hypotension, hypertension, stroke, angina. We can actually raise the glucose levels, and we can cause tissue necrosis if a catecholamine that's given IV ends up leaking in the surrounding tissue. Now, of course, with any topic, we got to talk about the nursing process. We're going to assess our patient's condition before therapy and during therapy and after therapy. And we're going to keep an eye on that EKG, continuous monitoring, blood pressure, pulmonary artery wedge pressures, cardiac condition, urinary output. We're going to look at the electrolyte levels. We're going to look at everything throughout therapy. We're going to assess for adverse reactions, drug interactions, acidosis, anything that can decrease the effectiveness of the dopamine. After dopamine is stopped, we're going to watch closely for a sudden drop in blood pressure, and we always need to assess the patient and their caregiver's knowledge of the drug therapy. What would you think of as some of the key nursing diagnoses for this class of drug and for these patients? Definitely deficient knowledge related to drug therapy. You can use that nursing diagnosis throughout this entire course. Acute pain related to a headache if they were to have a side effect. Risk for injury related to adverse reactions. We could have ineffective tissue perfusion related to whatever the underlying comorbid condition is. Decreased cardiac output relating to whatever the underlying condition is. And then we have to plan. And we got to look at our outcome goals. Measurable goals, attainable goals. Patient will maintain cardiac output. Patient will maintain effective tissue perfusion. Risk for injury will be minimized. Patient's pain will be decreased. Patient will demonstrate an understanding of the purpose and the intended effect of their individual therapy. And how would you evaluate this? How would you know? So patient regains adequate cardiac output, evidenced by they have, normal urine output or urine output greater than 30 mLs an hour, evidenced by stable vital signs, blood pressure of, 120 over 80, that they have a clear mental status, that they have adequate cerebral, cardiopulmonary, and renal tissue perfusion, that they don't have any injury, that their headache is relieved with analgesic administration. That patient and his family state that they have an understanding of the drug therapy. And how did you determined that they had an understanding. Was it a teach back? Was it that you had a conversation? Did you hand them out literature? Did you do, a pamphlet from the micromedics? Like, how did you establish that they understood what you were talking about? We talked a little bit about the beta adrenergic. What about alpha adrenergic blockers? They work by interrupting the actions of the catecholamines, epinephrine and norepinephrine, right at that alpha receptor. And this is going to result in relaxation of smooth muscle in the blood vessels, increased dilation of blood vessels, decreased blood pressure. Some of the drugs you might see are prazosin, doxazosin. They fall into this category. So alpha adrenergic blocker like prazosin inhibits the alpha receptors, causing arterial and venous dilation that reduces peripheral vascular resistance. And we usually use this in mild to moderate hypertension, but you will see it used a lot in mental health therapies, in the use of for people who have a lot of PTSD nightmares. Pharmacotherapeutics, because alpha adrenergic blockers cause smooth muscles to relax and blood vessels to dilate, they will increase the local blood flow to skin and other organs. Therefore, it will reduce blood pressure. So where would we use this? We would use it in hypertension, right? Because we want to lower that blood pressure. We will use it in peripheral vascular disorders, especially those where we have blood vessels that spasm, causing poor local blood flow, like Raynaud's phenomena. That is one where we'll use alpha adrenergics. Acrocyanosis, people who have frostbite, people who have pheochromocytomas, or a pheo, which is a catecholamine secreting tumor of the adrenal gland. We use it in vascular headaches. And one of the major results is orthostatic hypotension. And what do we mean by orthostatic? That is when a person's blood pressure drops when they change position from lying down to standing. Usually, the blood vessels in our legs will push the blood back up to the heart. And in some patients, that mechanism does not work properly. And when they stand up, the blood pressure drops and they get dizzy. And if you're following along in your book, what type of assessments do you think we would do for patients on these medications? Obtain vital signs, especially the blood pressure. We're going to assess the patient for adverse reactions. We're going to assess the patient for their knowledge of their drug therapy. What are key nursing diagnoses for this patient? Decreased cardiac output, ineffective tissue perfusion, acute pain, excessive fluid volume, because they're going to have fluid retention. They could have deficient knowledge. That one will always be for every drug possible, deficient knowledge related to drug therapy. What are some of our planning outcome goals? Adequate cardiac output, peripheral tissue perfusion will improve, as evidenced by circulatory checks and pulses within normal limits. Patient will state that their pain is decreased. Their fluid volume status will remain adequate. They will have adequate blood pressure, adequate urine output, and adequate cardiac parameters. Beta adrenergic blockers are the most widely used of the blockers. They prevent stimulation of the sympathetic nervous system by inhibiting the action of the catecholamine on that beta adrenergic receptor. We talked about the alpha, now this one is the beta. Some of the betas are very particular about which receptors they go after, and some have a really wide scope of receptors that they will go after. So beta 1 receptors are usually in the heart, and your beta 2 receptors are in your bronchi, they're in your blood vessels, and they are in the wall of the uterus. So we have non-selective beta adrenergic blockers like labetalol. And we have selective beta adrenergic blockers like atenolol or metoprolol. And remember back to week one's lecture, we talked about learning your pharmacological root words. So OL ending in the particular generic drug name will signal your brain to remember that this is a beta blocker. If we have a beta blocker that goes after beta 1 and beta 2, so they're not just going to reduce the stimulation of the heart, they're going to go after the bronchioles of the lungs as well, which is fine for somebody who does not have any underlying lung disease. So if somebody has a history of COPD, of asthma, of things in that family, chronic bronchitis, then they wouldn't want to take a beta adrenergic blocker that goes after the lungs. So propranolol, which is widely used for antihypertension, cardiac failure, it's used in migraine prophylaxis, it's used to reduce anxiety, it's can be mixed with an alpha for your pheochromocytomas. That's not a good drug for somebody who has underlying lung disease. So going back to that nursing process, we're going to assess the patient's condition before and during therapy. We're going to assess their respiratory status, especially if they have chronic obstructive pulmonary disease or asthma, because we're looking at that potential risk of having bronchospasms. We are going to check an apical pulse daily. We're going to alert our prescriber about any extremes like a pulse rate that's less than 60. We're looking at blood pressure, EKG, heart rate, rhythm frequently. We're being alert for any signs of like an AV block or bradycardia. If the patient has heart failure, we are going to weigh them daily, and we're going to look for a weight gain of more than 5 pounds in a week, or more than 1 to 2 pounds in a day, because this person could be holding on to fluid. We're going to observe our diabetic patients for sweating, fatigue, and hunger, and any other signs of hypoglycemic shock. And we're going to look for other drug interactions. We're going to assess our patients and their caregivers' knowledge of the drug therapy. What do you think are some key nursing diagnoses? Risk for injury related to adverse central nervous system effects. We're going to have excess fluid volume related to edema. They're going to have decreased cardiac output because of hypotension or bradycardia. They could have deficient knowledge related to their drug therapy. Patients' chances for injury will be diminished. That's what we're looking for an outcome. Patient will experience normal fluid volume, as evidenced by adequate urine output and adequate blood pressure. And then evaluation. How do we evaluate these? We are looking that a patient remains free from injury, that they have no signs of edema, that they maintain normal blood pressure and heart rate, and that their patient or family demonstrates an understanding of their drug therapy. So let's look at a quick quiz. Which effect is expected when using cholinergic agonists? What do you think would be a effect that you would expect? Would they have dry mouth? Would they have tachycardia? Would they have pupil dilation? Or would they have increased bladder tone? This is a cholinergic agonist. What do you think they would have? And the answer is D, increased bladder tone. The effects of cholinergic agonists is increased tone and contraction of the bladder muscles. We use this class of drugs to treat bladder issues. They would actually have constricted pupils, because remember we're increasing tone and we are contracting muscles. We're dilating blood vessels, but we are constricting pupils. And they wouldn't have tachycardia, they would have bradycardia, and they would not have a dry mouth. That is an anticholinergic. Which drug would the nurse give to a patient experiencing a symptomatic sinus bradycardia? Right, so they are having this low heart rate, but they're symptomatic and they need to be treated. Would we give them atropine, belladonna, digoxin, or propranolol? And the answer is atropine is the drug of choice. Dig slows the heart rate down. Propranolol slows the heart rate down. And belladonna slows the heart rate down. And the person already has low heart rate, so the only viable answer there is atropine. Which drug is a catecholamine? Dopamine, albuterol, prazosin, or labetalol? And the answer is dopamine. Dopamine is the catecholamine that is in that list. And thanks for stopping by the week 2 lecture on review of the neurotransmitters and the autonomic nervous system. Make sure that you review all of your chapter highlights before sitting down and taking the chapter 12 quiz.